Okay, welcome back to the next episode of the Pediatric Practice Management Media Cast. So I've got Brandon with me. Brandon, say hello.
Hello, Mr. Hart. How's it going?
I'm doing well, thanks. How are you?
Doing pretty good. Doing pretty good.
All right. So, Brandon, what did you want to talk about today?
Let's see, Chip. What could we talk about? I've been working a little bit on reports and trying to get better at running some reports and identifying what are the reports that really help me to decide how my practice is doing and things like that. So my guess is that because you've visited so many practices and you've looked at that you probably have in your bag of tricks a couple of reports that you look at to kind of identify the health of the organization or that practice. And I'd like to kind of ask you on what are the things that you look at, what are the metrics that you look at, and perhaps if you can start from the top in terms of like a really high 30,000 feet view, if you will, and then maybe as we continue talking, then maybe we can drill down a little bit further into one of those each one of those metrics. How does that sound?
That sounds great. And to be honest, I think it might take us a couple episodes to hit each of the highlights.
Okay.
So what I'll do is I'll cover one today. I'll cover something today that I think will last us this episode, and it will start both with the 30,000-foot view, but I'll show you how I drill down into a practice's numbers when I do my consulting work.
Okay, excellent. So let's start here. Let's say that I'm going to call you up, and I'm like, Chip, I need you. We're not doing too well. I think there's areas of improvement. And you come in, take a look at what we do here, and where would you begin if I were to call you?
The first thing I do when someone calls, I get these calls literally every week, and the first thing I do, and let me back up actually and say, to an extent, there's an analogy here that I think works. I'm reluctant usually to make this analogy, but imagine as a physician, if you were a physician, when the patient comes in, the mom says, here's my son, he isn't feeling very well. You have to start somewhere. You have to say, well, where what doesn't feel good? When did this start happening? You have to do your history. You have to do your review of systems. So what I'm going to do is I'm going to show you how I use some of the objective measurements by taking some vital signs and combining it with a little bit of a review of systems and a history. We can start to unveil things in a practice. Now, what we unveil every time is different, though there are some patterns. I will say that there are probably about 5 vital signs. It might be 4, it might be 6. We'll find out when we go through it. There are 4, 5, 6 vital signs that I like to take with every practice right at the beginning, because it gives me a sense of who I'm talking to and what the problems are. And there's one in particular, the one I like to start with. It's probably the most important one and the one that we can go into the most, and it's very easy to measure. And I'll describe that, and I'll give you some examples on the screen, and I'll show anyone who's listening or watching how they can calculate this number for themselves and give them a sense of what you can do with these numbers. How's that sound?
So let's
All
see
right.
more of it.
All right, so the first number I look at, this number is one of the holy grails. I know there's only supposed to be one holy grail, but there are multiple, and one of the holy grails of this business is to determine your revenue per visit. It is an easy thing to determine. It's vitally important. I'll show you an example of what a revenue per visit report might look like, but the calculation is very simple.
All right, let's start with the calculation.
Yep. Yeah, right. So to calculate your revenue per visit, it's really easy. You take all your revenue for a given period of time. I'm going to suggest that you look at least a year, because pediatrics is very cyclical, and you don't want to have the summer well visit flood affect your conclusion. So you want to use at least a year, and this is important, you do want to look at whether or not you're excluding visits that haven't been paid off yet. If you run a revenue per visit report right up to yesterday, your claims from yesterday most likely haven't been paid yet, so that could have an effect on the results. Now, if you have a whole year, it might not have a profound effect, but nonetheless, what I tell people is either use their billing systems to exclude visits that haven't been paid yet, though you do have to then adjust for volume, all right, because if 5% of your visits are missing, it might have some volume impact. Or alternatively, unless you really have a collections problem, run the report for a year, but backdate it a month or two. And yes, it means there's still some outstanding money that you need to collect, but for most most of our practices, their 60 days and over is only 5% or 8% of their AR. So, it's safe to say balances that are 2 or 3 months old, or a visit that's at least 2 or 3 months old is.
So, for example, we could run a report for 2012 and then run it like today.
Yep.
And that would give us a really good idea of everything, because we can assume for the most part, a lot of it is paid. The grand majority of all the charges that got sent out in 2012 got paid at this point of the year. Right?
Absolutely, you're going to be 99% collected, and it's going to be close enough for you to start making your.
So we get that number, we add it up, we find out how much that number is, and it's in the trillions of dollars. Okay, next.
Yep. So then, what you do is you count up the number of visits your practice had last year. Actually, let me rewind that. I wish I could rewind our video. Make sure when you count up your revenue, your payments, that you include any, pay for performance payments, PCMH boosts. Don't include your ARA, because those aren't payments from the payers themselves, but you need to include any revenue, any payments that you receive. It still shocks me to learn how practices just sort of take their cap payments and deposit them without actually applying them to your work at all, because those cap payments are a key part of your income for some practices. So don't forget to include all your revenue. So then, once you've done that...
Okay, let me stop right there. Because that's a very important point. So I understand capitation payments, but what if you get rebates from insurance, rebates from our friends, from the pharma friends? Like we participate with GSK, and they have this rebate program that if you
don't
be equivalent to our work. Do you include that in there?
No, I wouldn't. That's a good question. No, I wouldn't include that in there, because even though that's revenue, and revenue that you wouldn't receive without performing those services, it's revenue that you can't readily assign to a particular payer, first of all. You could, if you wanted to get really fancy, distribute that revenue across all of your payers based on their volume, or maybe even based on the utilization of your vaccines. But as a rule, I would say no, because that payment comes from outside the payers. But
okay, so that's a good rule then to remember. If it comes from a payer, apply it. If it doesn't come from a payer, it's icing on the cake.
Yes, that's what I would call it right now. I think some business accountants might not agree with me, and they'd have right to do so. But for right now, we want to keep it simple. And yes, I realize in a big practice, those rebates might be substantial. They might, in fact, change your view of a few things. But for what we're going to do, probably not. It's a good question, though.
You can also look at it as it just occurred to me, instead of revenue, it's more, it can go towards the cost as opposed to it's cost, it's cost savings.
Right.
So that's another way you can look at it. But okay, let's move on.
Okay, so now one of the questions that people often give me is, well, what's a visit? Do you count hospital visits or visits that happen outside the office? At PCC, we do, because that hospital work is intrinsic to your work in the office. Yes, I realize you could become a hospitalist, or that's silly, but you might end up doing more work in the hospital. But the time that you spend in the hospital, those visits are things that you're billing for specifically, and it's time that you're not in your exam rooms in your location. So we tend to count everything. Whether you choose to or not, that's up to you. But just make sure, if you don't want to count things like hospital visits, or you don't necessarily want to count a request for a school form as a visit, then you just need to exclude those from both your visit count and your revenue count. That's all.
What about like flu shot visit? Is that a visit? Do you include that as a visit or no?
Yeah, I do. I very much do. And in fact, one of the things that we saw in 2009 when swine flu hit is PCC clients' average revenue per visit dropped for the first time in 15 years. But their total number of visits went way up, like 20-30%. So as long as you're sophisticated enough to understand that a high volume driver can in fact lower your revenue per visit average, that isn't necessarily a bad thing. But it is something you have to keep in mind. It's a great question, Brandon.
All right.
So what we do, though, all right, is we take our revenue figure and we divide. I don't know if I can do this on the screen somehow. We take our revenue figure and we divide it by the total number of visits, and that gives you a revenue per visit figure. I'm going to show you what a report like that might look like. I took a PCC report and I dropped it into a spreadsheet, okay? So let me look at this one. I think this one will work, okay? So here's a very simplified version of this report, okay? Very simple version. And can you see it on the screen?
Yes, I can.
Okay. So what we do here is now...
Chip, for those of them that are listening, can you just describe the columns then? What are we looking at?
Absolutely. So what I have is I have 5 columns, all right? And in those 5 columns, in the first column, I have a column where I break this report down by payer. That's a second round thing. I'll get to that later. If we want to look at just this row, this total row, I have the following 4 columns, all right? I have the total number of visits, all right? In this instance, it says 25,000. And then over here to the right on my spreadsheet, I cleaned it up, okay, took it out. I end up with a total dollars deposited, and I divide the total visits by the total dollars deposited. And in this sample practice, I end up with a figure of $127.48 per visit. The 2 other columns I track, and I'll explain these in a few minutes. I track charges per visit and the average charge per visit. Now this is a very simple report. For people listening, I'll put a sample of this report up on the podcast, and I'll put it in the Google community groups. And Brandon, you can post it on your page. This is a very simple report. I mean, it's literally a report that technically could have 4 numbers in it: visits, charges per visit, average charge per visit, average deposited or average paid per visit. Very simple. And I love this report. Whenever a client calls me, while they're talking to me, they, because I'm a nerd, I type while I talk on the phone. While they're talking to me, I fire up their dashboard, or I call into their system, and I run this report while they're talking. Here's why. This is the first thing I do. The first number I jump to, all right, is this one right here. The average
is the average deposit per visit.
The average deposit per visit. And in this instance, for this sample practice, it's $127.48. Now that number in the raw has limited but valuable use, okay? I know right now that for PCC clients, the average revenue per visit is about $118. All right, I think that's what it is. I haven't looked at it in a little bit, but let's round it and say $120. Now I know your position on benchmarks, Brandon. Don't worry. So you have to take that in context. But I know right now, Brandon, okay, if you call me up next week and I run this report and I see, and you call me up and you say, we're having trouble making ends meet, or the doctors are upset about this, or we've got a problem here, and I run this report and you're at $127, guess what? Your revenue is probably not your problem. All right, your payments are probably not your problem. Of course I make some adjustments. If you're calling me from Manhattan, from East Bay, from downtown Boston, some of the 3 most expensive places in the country to own a practice, well, maybe 127 is not enough. But if you're calling me from the suburbs, if you're calling me from Kansas and you're at 118, guess what? The money coming in is probably not a problem. Now, if you call me up, actually, I was working with a practice yesterday who is at $85 a visit. Okay, at $85 a visit, I don't care where you're practicing, it's going to be tough to make ends meet. So the first thing I can do by running this report takes 1 second. I'm just counting visits and I'm counting dollars, and I divide those dollars by visit. And if I'm talking to a practice that's in the 95 to 105 range, and they're not in a particularly rural area, or an area that I think might be less expensive to practice pediatrics in, I know that right away this is a practice. Now I need to go look at those other items. I need to go look at their coding. I need to go look at their collections and so forth. Okay. Now if I'm talking to a practice who's at 115, 120, 130, 140, this isn't where I need to do my work. So that's part one.
Somewhere else. Okay.
All right. So, and that number right there, if you're in a room at a seminar, okay, if you go to one of Paul Vincieri's seminars, like we talked about the other day, or you go to a PCC one or an AAP one or whomever else, all right, this is a number that you should carry with you in your pocket, because more and more of these practices who show up at these events know this number, and you can say, well, what's your revenue per visit? How much do you make? And what's key about this, okay, this number is sort of a hinge pin for so much more of what happens at the practice. With this number, all right, you can also then calculate, if you apply your overhead to it, All right, so Brandon, I'm gonna make this up. Let's say that you have 50% overhead. You probably have 60, 65%, but 50% is a lot easier for me to do the math in my head. All right, so it's 65% overhead. What this means is you have about $63.50 of every single visit goes to paying off your staff, opening
Yeah.
the doors, getting your vaccines, whatever the case may be. And the remaining 65 cents goes to the partners, the owners of the business. In this instance, it's probably more like, 75-55 or 75-40. That's just my guess. So
Yeah, I hear what you're saying. I use this number. I've done it before, where in addition to grab the number of patients seen and divide it by the total revenue that came in, I
yep,
also divide it by the number what our total cost was for the year.
yep, absolutely.
And I might get fancy and might include the doctor's salary. Sometimes I don't, but that just gives me an idea on how much how much of this money that's coming in is going towards our cost. So it's easy to say 127, but obviously the 127 is not all that's coming into our pocket. So when you divide, so you have your average deposit per visit, and so you got that number, and you divide that number by your cost. That's how I identify how many patients I have to see just to break even.
That is absolutely one way.
Yeah, that's one way, but it gives me a really good idea to say, hey, at the very least, we need to be seeing this much, because if we spend the same amount of money that we did last year and we collect the same amount of money that we did this per visit, then that means we need to see this number of patients, because the math tells us now. It gets you can get, like, as you well, for those that can't see, Chip also has here a analysis by payer, and you can see the difference.
I'm gonna get to that.
Average. But my point is that if you happen next year to see more of your higher paying patients, then obviously that number is going to change. Or if all of a sudden everybody loses their job and they go to Medicaid, then you're going to have to see a lot more patients then just to remain the same. So it gets a little bit tricky. But my point that I wanted to bring up is that number can help in many other ways, is what I wanted to stress.
Yeah. You are absolutely correct, and it's like I said, it's the hinge pin. It's the I bring back my analysis to this number over and over again. And in fact, when I go and consult for a practice, and I leave them with some advice, and they use some of that advice, the first thing I measure when I come back is this one right here. For 3 months later, I look to see, did their revenue per visit change? Because if it didn't, I probably didn't have the effect I wanted to. This is key. Now, one of the things
in here real quick is I know we talked about this already, but this is actually a practical example, and I know probably people are listening to that. Is they're going to do this number, they're going to get one, and they're going to say, well, is this number good or is this number bad? So why don't you really quick tell your analogy about if I'm an average guy and I weigh 185, is that a good weight or not a great weight? So give me that story real quick again, because I think it's good to bring it up.
Yeah, every benchmark that you have needs to be taken into context. And, as Brandon said, if I tell you my weight is 185, and Brandon, that's a pretty good guess in my instance, is that good or bad? Well, if I'm 6'9", that's probably not very good. But if I'm 5'6", and I'm taller than that, everybody, believe it or not, if I'm 5'6", 185 is probably a little heavy unless I'm weightlifter. If I tell you my pulse right now is 48, knowing whether or not I just got off the treadmill might have a big impact on your assessment of my pulse. And so you have to put this in context. In the context outside your practice, I will tell you that I like to see practices these days between $110 and $125. Right, as a rule, if you're outside of those ranges, I need to start getting some external context. However, there's what's really important for context. What's vitally important for context is comparing to yourself. All right, telling you that I weighed 185 pounds is not as important as me saying, well, and I weighed 175 last year and I weighed 165 2 years ago. Well, I'm going in the wrong direction. This number is so easy to calculate. There's no reason why you can't calculate this number on an annual basis going back the last 5 years. All right.
Yeah, I like what you said in terms of the benchmarking is, okay, you have a number. You don't really know if that's a good number or not. You did get some parameters. So let's go say I'm falling out. But to be intentional about this number, say, okay, we're going to improve it. Here are things that we can do to improve it, and then running it 3 or 4 months down the road, and then comparing it then. And I think that will let you know if you're on the right track or not.
Yes, and I will say unequivocally, if you calculate this number back to, like, let's say 2003, say there's a 10-year range, the only year that I would suggest that is acceptable across the spectrum to have a dip in this number is 2009, when most practices had a huge swine flu.
Yeah.
Everyone else.
Back, I really think that the most 2 years, and really I wouldn't focus more beyond the year in my view. I mean, why do we care what happened in 2005?
Because you want to see if your practice has a trend over time. All right, that's all. You want to be able to say, look, you know what I hear all the time, Brandon? I hear this every day. We're getting killed. We're not making as much money as we used to. If I look back at our clients in 2003, PCC clients were getting like $65, $70 a visit. Okay, so why is it that in the last 10 years the revenue per visit has doubled, yet people still feel squeezed? Well, there are some legit reasons, but by and large, if you as a pediatrician are not generating significantly more revenue on a per visit basis than you did 3 or 4 years ago, that is a clue to me that I need to go looking around in other places. All right. If I don't see a consistent upward trend, you know what this is? I would compare it to, Brandon. This is a growth chart. Okay. If you're not on a growth chart that follows the pattern of all the other pediatric practices I've seen, I'm going to dig around and find out why the revenue per visit went down.
Yeah. All right.
Does that make sense?
Yep.
All right. Now
let's talk. Let's jump in here. You break this down a little bit further into insurance.
Yes.
So where's the value in that?
All right. So this is part 2. All right. And I might have, I don't know, 2 or 3 parts of this. So the first thing I'd like to do, if your vendor can do this, and pretty much any vendor can do this now, where you count the number of visits that you had and the total amount that you charged and were paid by that vendor for the time frame, you can calculate this number on a per payer basis. Now, as an aside, let me explain one thing. Most practice management systems don't have a decent way to count visits. So a quick and dirty way to do a visit count, all right, if you don't know how to do it. This is inexact, but close enough for what we're going to do. The easy way to do it is to count up E&M visits. So count up all your 99201s through 205s, 211s through 215s, 381s through 385s, 391s through 395s, and then your hospitals. Count those up, and that's your visit total. Believe it or not, you have more visits to your practice that don't have those codes than you imagine. Okay, for example, all those flu shots, all right, for most people. But for the purpose of what we're going to do, that's just a quick and dirty way to do it.
Yeah.
Now, when you get this number and you can break it down by payer, suddenly, all right, it's as though you've turned on the lights in the room. So this practice, for those of you who can't see it, I'll explain. This practice averages $127 of revenue per visit. All right, so I like to then look and break it down by payer, because I can see that United Healthcare pays $152 a visit, and Oxford pays $118, Medicaid pays $80, Cigna pays $163. That's quite a swing. All right, so the first thing this tells me is, boy, which insurance companies might I start negotiating with tomorrow? Okay. If this practice comes to me and says, I'm not making money, I'm going to jump in right here and say, well, you know what? You have a private payer named Oxford paying you only $118 per visit, when it's not even their sister, their ownership company, United, is paying you $152.
Yeah.
All right. So that's one item. That's a key item. Which payers am I going to start targeting to zap? Okay, that's part 1. Part 2, on the flip side, I'm going to say especially if I'm going to do something like drop Oxford, and I want to replace that divot, which of these payers am I going to go after to do patient recall? Now, you might be able to run the same report. I can give you an example, but I'll just describe it. If you could run the same report that breaks it down by visit type, so you can get your average revenue per visit by sick encounter and by my well code encounter, I want to be clear. Do not simply look at the E&M codes to make the comparison. You really have to have an understanding of the mix of what happens at a visit. At a 99392 visit, there are dozens of immunizations and admin codes and all that, and developmental screening and vision and hearing. And so you need to have a sense of when it's a Blue Cross Blue Shield visit, I get $273 for a well visit and I get $90 for a sick visit. Assuming you can do that. If I see a payer like United paying $152, it's a pretty safe assumption that United probably pays well for well visits. I can't believe I just said those words, but maybe in this instance it's true. So if I'm going to fill in the divot left by Oxford, I'm going to go after the United patients because, with my patient recall, to get them in for their well visits, to get them in for missing shots, to get all that stuff, because they're the ones who are going to pay me well. And so that's why I really like to break it down. The other
important point that I think is if people get afraid when they're going to potentially think about dropping a payer. So let's use this. Okay, so on this list we have an insurance called Affinity MA.
Yep.
Their average visit is $99. All right. Now the number of visits is a boatload of visits. It looks like it's the highest one.
Yep. I'm going to show you a trick. Keep talking.
So there's that's what I was going to say. What is the percentage of patients seen for that payer? So it looks like they are the largest number of visits, but they are the one of the least paying average per visit
payers. Yeah, absolutely.
Right. So the thing is that if you were to drop that payer, we're looking at 6,282 visits that we would not have.
Correct.
But that's not really the case. It's less visits because those are only paying you $99. If you were to find somebody that pays you $152, then you would have to see 6,000 patients.
That's absolutely right. Yeah, at $99, okay, that's the equivalent of a 30% discount on everything that happens. So you can say if you need to replace 6,200 Affinity visits, you only need about 4,000 United visits to do that.
That's what I was trying to say. You said it much better than I just did. That's what I wanted to say. It's like you don't need to fill it. You don't need to find another 6,000 patients. You only need to find. So what is that? So let's go say 99 times 6,282, whatever that number is. You really only have to replace that number, not the number of patients, just the dollars.
Correct. And it may not be the case with Affinity MA, but let's say, okay, I'm going to tell you right now that Affinity MA is a private Medicaid. Well, here's another private Medicaid, Health First MA, at $123, which is a 25% boost over Affinity. Okay, yeah. So maybe what you're doing is trying to figure out how to move your patients from Affinity to Health First. All right, in some states with the private Medicaid plans, that's a very viable option.
All right. So I think we digressed just a little bit because now we're talking about dropping insurance or everything like that. I think that we should recap here real quick because we're at the 30-minute mark, and we can certainly stick around if you're ready with that, Chip, and maybe talk another 30 or 40 minutes or 20 minutes, whatever we feel like it. But for the video cast, I want to go ahead and stop it here and then just kind of recap real quick before we say goodbye and meet the people on the other side that are going to stick around with us. So what I hear from you, the really critical number that we should be looking at the very beginning is to identify what is our average deposited per visit. Not what we bill, but rather what we collect on a per visit. And the way that we do that, the easiest way, is that if we add up all of our number of visits that we saw, ideally for the previous year, a good 12 months prior, and we divide that number by the by the amount of money that we made. So all the money that came in into the practice for that year, by the number, divided by the number of visits, and that's going to give us an average, what do you call it? Like revenue per visit, right?
Revenue per visit.
Yeah. So with that number, then we can, start getting a little bit more sophisticated in terms of identifying if we're doing well, if we're not doing well, if we need to improve. We can use this for budgeting. I know that last week or a couple of weeks ago with Paul Manchier, he was saying that we can use that number for budgeting purposes. I use that number also for cost analysis. So there's various things that you can use with that number, right? Is that a good summary there?
That's absolutely true. This is an easy number to calculate. It's a vital number to calculate. And in the second half, I'm going to show you what the residual data that you get from calculating this information as well. So we'll cut the video here, and now we'll move into the podcast. So Brandon, what I did while you were talking there is if you look at the screen now, I just added 2 quick columns to this report. All I did is use a spreadsheet function, okay? And what I did, because I can break the visit, because I have the number of visits by payer, I then calculated a new column showing on the payer basis my visit volume. So I can see, for those of you not visual at the moment, I can see that Affinities makes up 25% of all the patient visits, while Blue Cross Blue Shield makes up 23%, and Medicaid makes up 5%, and so forth. This is an important tool. It gives you a sense of, hey, if I have 100 kids walk in every day, 25 of them are going to be Affinity MA, which is one of my worst payers. Yeah. All right, and that's what's interesting to me. I will tell you, I ask people all the time. This is something that doctors do. I mean, the doctors listening to this know this. A patient comes into your office, and even though you know or can determine the answer to the question, you ask your patients the question because their answer and how much it differs from reality ends up being really important. I see that all the time where, where I ask a practice, well, what percentage of your business is Aetna? And they say, oh, 20%. And I say, well, no, it's 7%. All right, now, the other thing I did is because I calculated charges per visit, which was easy. We're in there, we're doing payments, right? Charges are going to come with the report 90% of the time in most practice management systems anyway. By calculating charges per visit, I can then come up with a really quick collection rate. And I can see here that Cigna pays on 53% of all of their charges. So for every dollar charged, you get 53 cents. Medicaid's closer to 31%. Okay. Now I'll save for another time a discussion about what that number, I normally see that number being. But this gives you, when you do it for yourself, when you're doing a benchmark for just you, this tells you which payers are generating the most revenue for you from a collection standpoint. You may see that some payers are harder to collect from than others. You may see that this puts it, that when I find this useful for, this often puts into perspective for the doctors, how much they are getting hit by certain payers, especially the private payers. When I see right here, okay, that Oxford, actually I'm going to, pardon me, I'm going to get into something somewhat sophisticated here, okay? I see that Oxford pays 42% of the charges to it, while United pays 48%. Okay, so they have a 6% difference. Now, just as an aside, that's really that 6% difference as relative to their total payments is a lot higher than that. Obviously, it's about a 12% difference because that's 6% relative to 42%, so like 1/7, probably closer to 15. Anyway, you'll notice though, come over here, Brandon, and if you take a look. This is a sample practice, so it might not make any sense, but they charge on average $285 for an Oxford visit and $317 for a United visit. And their sample size, this is over thousands of visits. This isn't just a 5-visit weird sample. There is a significant difference in this practice between Oxford and United over what they charge. Now, there's sometimes some very legitimate reasons for this. You have a different payer mix. or patient mix within that payer. You've got an older group of patients here, or in the case of Medicaid, maybe you've got a more clinically difficult group of patients to work with. But I'm not aware, for example, of why a practice would have any real difference between Oxford and United Healthcare when it comes to the clinical distribution of the patients. And so why these two practices differ by, let's see here, by 10%, okay? Why there's a 10% difference in pricing for them, that's interesting. And now we've fully identified something that I would dig down into. If I look at Medicaid, the number's even higher, all right? It's closer to 20%. And there's no reason why your charges for Medicaid patients should be 20% lower on average, all right, than they are for United. And look right here, Brandon. This is my segue, okay? Because in the process of counting up visits, most of you will also need to count up total procedures. And by total procedures, I mean everything. Take a look at this, Brandon. In this practice, United Healthcare averages 4.01 procedures per visit. Oxford 3.68. All right. So there is a 10% difference almost in the volume of procedures done at United visits versus the volume of procedures done at Oxford visits, which explains the charge gap, which explains a big chunk, but not all, of the payment gap.
Of the difference of the payment. All right, see, that's awesome on how this simple report can kind of lead you towards that path to make that, to make that conclusion.
But Medicaid has 3.78 visits or more procedures than Oxford, yet they charge significantly less. So unless for some reason Medicaid has a very different clinical spread of procedures, I'm going to guess that this practice either is doing something funny with their pricing, or there are charges that they don't post for Medicaid, or there's something here. Right away, by looking up the revenue per visit, the residual data that we gather from it, charge per visit and charge, the average dollar charge per visit and the average procedures per visit, now suddenly I have a clue. All right, and now I have something I can go do a little, let's call it forensic accounting, and drill into this item right here.
Okay.
And so does that make sense?
Yeah, it makes sense. I'm just hoping that the people that aren't looking at this chart, it makes sense for them too. It's visual for me because it's easy for me because I'm looking at it, so it's easier. But so what I wanted for those that are listening. I want to be sensitive to them. So basically, the report that we're talking about is able to give. Chip just gave a great example of how the report can lead us to identify one of the issues, and that's kind of the reason why I wanted to go down this path, because I knew that there are certain key numbers and metrics and stuff like that will give us a good idea in terms of what's up with our practice. What are some of the pain points? What are some areas that we need to focus on, we need to improve. So that was basically a really long way. If you're nerdy like us, then you can basically listen to that and be right at home. But if you're not that nerdy, the point is, and you got really bored after that nerdy discussion, the point is that here's a really easy way to run a report and then to start digging deeper and actually a very productive, like Chip just said, forensic accounting or forensic practice management process to help you identify the areas that you need to improve in your practice. So I thought that's great. And when I did that the very first time, about a year ago, I hate to admit it, I did it about a year and a half ago. It was the very first time I broke it down. I knew what the number was, but I had never broken it down by payer. And that was like turning on the lights. When you see that, you're like, oh my goodness. And I did exactly what you did. I started doing percentages because I noticed that there was these discrepancies in the numbers. So we were seeing a ton of patients, patient counts, but it only represented a very small number when it came down to money. So I'm like, well, we're almost like spinning our wheels here. We're seeing this many patients. It's costing us just the same as any other patient, yet we're being paid less for them.
Well, let me ask you a quick question.
It's very easy for me to say, I need to go talk to this guy right here. I did, and there was one insurance company that stuck out like a sore thumb, and that was the very first one that I went to go speak to, and I did make some improvement, not as much as I would have liked it, but hey, I would have not known to make that improvement in terms of our payment had I not seen that report, and had that report not prompted me to go, then I wouldn't have gotten that.
Well, let me ask you a quick question. How hard was it for you to come up with that data?
It took a little bit of the average revenue per visit was not difficult at all. Because of the way our system was set up, our previous old PM system, it did require me a little bit of data dumping into Excel and then cleaning it up. And the reason why is because I don't know if I even need to go down this road, but basically we didn't have just one United, we had like 15 United, because each one went to a different address, and so the report didn't, for whatever reason, it didn't know that all these were United. So it appeared that we had, I don't know, like 100 payers, when in fact we had just the basic, 5, 6, 7 payers, but I had to clean that up. So we had like 3 or 4 Blue Cross. We had like, United was the worst. We had like, I don't know, like 10 Uniteds. And same thing with Cigna. We probably had 3 or 4 Cigna. So that's why it took me a little while to gather that up. But in general, I mean, when I say it took me a little while, I'm talking about a morning.
Right.
I'm not talking about a week. So
yeah, and that's key. A lot of people don't do this work because they're afraid of how long it's going to take, or it's too big a project, and it's really not. That's one of the reasons I like this number.
Right.
One of the things I'm going to suggest is sort of a corollary to what I showed before. I'm going to zoom in a minute on an example. Let me see if I can get you a good one here. One of the things that I like to tell people is, okay, so we've been talking about the volume, or pardon me, the dollars, the average revenue per visit over, for this time frame or that time frame. But once you start breaking it down by payer, once you're in there doing the work, I also encourage people to look at your volume over time by payer. And let me do this, Brandon. You tell me if you can see this on the screen.
Volume over time by payer. All right. So what does that tell us?
All right. So
more estimations from that payer.
Right. So can you see this graph right here?
Yes, I can.
All right. So this is, just a shot from a dashboard program. And so in this example here, you'll notice that the Blue Cross, which is the blue line, the volume of Blue Cross increases very steadily until 2007, and then slowly drops. It pops back up here. But look at Affinity, okay? And Affinity being the payer which we just identified as, I happen to choose this on purpose, but Affinity being the payer we just identified as being a very poor payer. And we want to move these people over to HealthNet. So watch this. Let me regenerate this with Health First, okay? We're just going to do this quickly. All right. So let's see if there's a change to our Health First volume. Health First is yellow. Health First is this slow, steady increase. But imagine if all of these patients right here, the volume in 2009 was about the same, but up through 2011. All right, I don't know what time frame I ran this for here, but up through 2011, you'll notice suddenly that the Affinity took off. Now, if those two bands were reversed, all right, if we go back to our other data, those two bands were reversed. We're talking about 2,000 visits times 25. We're talking about this is a $40,000 to $60,000 a year gap right here. All right, every year. Yeah. So given this split started in 2009, and it's now 2013, and we're talking about $250,000. You're talking real money, and so that's why I like looking at these trends over time.
It just occurred to me that if more practices would do this and they would see that particular payer, because it's obvious that payers sometimes will pick a region and they'll muscle their way in. They'll offer these really crazy cheap rates. Where all the companies in the area will switch, to them, but of course they make that back by not paying the doctors very well. But nobody knows this until after the fact. So if you would see that, okay, we have a payer muscling the way into the marketplace. I talked to one insurance company, and they're like, last year, and it's like, our goal is to take away market share from the leader in this area. So we're willing to do whatever it takes to do that. So they were very honest about that. But what happens is that if all of us would do that, then we would say, wait a minute, and then we're not going to see anybody else from that people, because look, they're muscling their way in, they're offering great rates to their members, but they're making it up with they're subsidizing we're subsidizing it essentially. The doctors and the hospitals essentially are subsidizing their discounting, and if we would band together, and I'm not saying share and get into crazy what do you call those Stark law, crazy stuff. I'm not talking about doing that sort of thing and banding together in that sense. I'm saying do your work on your side, identify the payers that are not doing very well, drop them or negotiate with them, because that's really the only way it's going to change. If we continue accepting those people into our practices, then they're just going to say, well, then why do we need to do anything other? But then once we start dropping them, then the companies that buy that insurance, the employers, are going to say, well, this network of yours is terrible. Look, you don't have any of our doctors on here.
Well, I often say that it's not just this is the truth. The overwhelming majority of successful insurance negotiations our clients have occur after they drop the plan. Yeah. And what I will tell you, one thing that the trend shows you, if you see an uptick in a vendor, or in a payer rather, that uptick may be because other people drop that plan and those patients don't have a place to go now. And I see that all the time. Say, look, if you don't drop this plan and one of your neighbors does, you're going to be getting even more patients from a low-paying payer. That's why I always tell people I like to be the first person to drop a plan in town. Let everyone else learn the hard way. But in any event, so this is one of a series of benchmarks or measures that I use. I think we can discuss the other ones in a couple more episodes. I'll give you a teaser. I'll tell you the other things I like to look at. Some of them. I won't tell you all of them. I'll hold some out a little bit. I like to look at the E&M distribution a little bit. Not a lot. I don't spend a lot of time on it. I like to look at the sick to well visit ratio. I do like to do an assessment of what I would call their recall capability. I'll describe that in the future. I don't usually care very much. I'll tell you one thing. I don't usually care very much about AR days and even AR. I only care if it's an obvious problem. What I find is that the variance of the AR in most practices is pretty small. 9 out of 10 practices do a decent job managing their AR, and it's only when someone's really bad at it that I care about it. A lot of consultants love to talk about AR days and everything like that, but I can just tell you the distribution of AR days for PCC clients is really narrow, and the ones who are outside of it, it's really obvious. And what else would I say? Well, I'll keep the rest of them a secret for now. So what I'll probably do the next time we talk is I'll look at E&M distribution, what you really need to know about it, and sick to well visit ratio, what that means and how to measure it. And I think those can be pretty telling. And I can say I as a consultant, using revenue per visit and these other measures, these are the numbers I use when working with a practice. And so I'll tell you about the other ones in the next episode.
All right, sounds good.
Awesome. Any more questions today, Brandon?
No, I think we covered a lot of ground. We got a little bit geeky there for looking at that report, and I think that there's good stuff in there. I mean, that report alone, and just kind of sitting down and looking for that, I mean, I think that's a great tip of the iceberg.
All right.
There's so much stuff that you can do that we didn't even discuss within that little report there. So I'm glad you brought it up. That's exactly what I was looking for. So yeah, I think that's good.
Great. Well, we'll be back soon, and we'll follow up with more reports, some special guests, and I encourage people to send questions in. We still love to hear from you. Thank you very much, and we will talk soon. Toodaloo.
All right.